Thanks everyone, and what a great session we've had so far, hearing about the PPP, the Footscray Hospital project, and the exciting work for electrifying hospitals. And now our panel discussion, Changing Climate, Changing Communities, where we will further explore those topics. My name is Anna Fox and I'm a Senior Associate at Grieve Gillette Architects. I'm also on the AHDC Conference Subcommittee and newly elected member of the Conference Committee. So firstly, I'd like to introduce our panel. Joan is the CEO and Project Co-Representative of Exemplar Health for Bendigo Hospital. Joan joined the Bendigo Hospital Project Co-Consortium, double J there, the design consortium during the design and construction delivery phase before moving into a leadership role as the project progressed through operations. Combined with her 20 years of architecture experience, Joan's involvement across the various phases of the Bendigo Hospital PPP have given her a unique perspective on its design and ongoing facility management. Bendigo Hospital is a multi-award winning project, and Joan will talk more about maintaining strong stakeholder relationships and bringing all parties on the PPP journey to achieve excellent outcomes. Next, I'd like to introduce Jake. Jake is a facility planner at Hunter New England Local Health District. He began his career as an ED nurse and holds postgraduate qualifications in trauma, critical care and health management. In 2018, he transitioned into clinical delivery, and by 2020, he was working in health facility design and construction with the Hunter New England LHD. Jake is now an experienced manager in the hospital and healthcare industry. He's skilled in clinical planning, infrastructure project delivery, leadership development, clinical leadership and quality improvement. Next, I'd like to introduce Kate Evans. She's the Clinical Director of Northside Hospital Project for Infrastructure Canberra. Kate is a nurse practitioner and a clinical director with over 25 years of experience in healthcare and more than a decade leading major infrastructure projects. Known for her transformational leadership, Kate combines clinical insight, data analysis, and strong community engagement to deliver inclusive, person-centred outcomes. Her work has been recognised with awards including the 2022 NAWIC Award for Diversity and Inclusion. She's overseen the $500 million Canberra Hospital expansion, the largest healthcare project ever undertaken by the ACT government. Kate will also be talking about the Canberra Hospital in Session 8 tomorrow with Julian Aston from BBN. Next, I'd like to introduce Max Sankauskas. He's a project team leader, engineering consultant, infrastructure corporate system support services for the Government of South Australia. He's currently project team leader for the Flinders Medical Centre redevelopment, which has just commenced construction on a new acute services building. Max was project team leader for the $314 million redevelopment at the Queen Elizabeth Hospital, completed in 2024. Some of you may have been fortunate enough to be involved in the site visit to the TQEH with Max yesterday. Given Max's extensive services knowledge, including holding a mechanical engineering degree, Max also provides engineering advisory support to other SA Health capital projects. So firstly, I think, like many of you, you might be intrigued by what Jake has to say about co-design. So I think we might just jump straight into it with Jake and have a little bit more of a chat about stakeholder engagement and in particular what co-design means to you.
Yeah, sure, no problem. Thanks everyone, thanks for having me here today. It's an exciting opportunity to network and share learnings across the national portfolio, which is really exciting. Set myself up before with that question, but my own personal views aside, as a local health district in Hunter New England in New South Wales, we've really been looking at what co-design means, and as I sort of alluded before, the concept of let's have a co-design meeting, we organise a meeting, we send out some invitations, half the people show up, we have a few of those, and then we say, yeah, we've done co-design. We tick the boxes in our strategy, which was in our project brief, and hunky-dory, we're on our way. We really wanted to flip that on its head and say, what's genuine about co-design and what do you really want to call it? So there's probably two pieces of work underway in Hunter, New England that I think are relevant in this space. One is very specific to a project that I'm working on now, which is the Maitland Mental Health Rehabilitation Facility. For context, it's a 64-bed forensic mental health facility. So in terms of consumer consultation, has some unique challenges by the nature of the consumer that we are meeting with. So we started talking about what a co-design strategy would be and what that would look like. And we knew that co-design would not be genuine if we just said, yes, here's the run-of-the-mill co-design strategy. So we sat together and we wrote with the carer and consumer team that exists within our mental health service, and we come up with what we've called the CCPT, and it's the Consumer and Carer Participation Team. So we know that it doesn't go to the full gamut of co-design, but what it has allowed is the utilisation of existing structures that we have within our service to make sure that we are doing the most genuine consultation and co-design that we can. So we're utilising the peer worker workforce that we have, people who have a lived experience of mental health concerns who now work for our organisation as peer workers. They sit in the project team at our co-design meetings, at our design sessions. They are then, empowered with the knowledge to go out to our mental health consumers, talk to them about what we're doing and gain their feedback. What this has done is create a safe space for consumers to feel comfortable to discuss and provide input to someone that they already know and trust, as in these peer workers have been working with these consumers for a period of time already. They then gather that feedback and bring it back to the project team. So rather than the project team parading into the mental health unit and saying, okay guys, sit down and talk to us about what you'd like to see in your new facility, and you get crickets. Whereas the peer workers are empowered with the knowledge, go off with the plans, have the conversations, come back with that information. And that's been particularly beneficial in that project specifically. I'm not going to chop all the time, so very quickly, the other thing that we're doing in Hunter New England Health is we've partnered with the University of Newcastle to develop this, and it's called the Emotional Design Brief. So rather than, you chatting to people about what colour vinyl they'd like to see on the floor or what colour vinyl they'd like to see on the walls, we have a series of interviews with a variety of consumers, carers, patients, staff, and very specifically have a conversation about how they feel when they're in spaces, what they'd like to see when they're in spaces, when this happened, how did that make you feel? All that qualitative data is then pulled together and developed into what we call an emotional design brief. Any of the architects in the room who have worked with Hunter New England will be familiar with this approach, and that's sort of the basis of what we then use to influence the design moving forward. My colleague Karen and Sophie have done a lot of work in this space of making this come to life. And really, it's our standard approach now to that co-design process across our infrastructure portfolio.
Fantastic. Thanks, Jake. And it sounds like a really good framework that you've been developing, and I like that you've also rebranded that and moved away from that terminology of co-design and made it specific for the project that you're working on as well. I guess just on the theme of stakeholder engagement, Joan, I'd like to throw to you. How have you considered ongoing stakeholder engagement given your role in the various stages of the Bendigo Hospital PPP?
Yeah, I think we've heard from PPP presenters this morning about the design phase and construction phase, and designers in the room will either be working on health projects from scratch, building new facilities, or they're redeveloping existing ones. And our PPP Bendigo Hospital has been operating for almost 9 years now. And I was part of the project during design and construction, and I've come back to it in operations. So I think I've made the joke, but commentary a few times already in the last couple of days that I have found it a singular experience because as an architect working during design and construction, making decisions during that phase, thinking, well, once it gets to CA, it's not my problem anymore, and then coming back in operations and realising that my fingerprints have been over a few things that haven't quite worked the way I thought they would. Making sure that stakeholder engagement is equally important during the operation phase is really important. And so it's, as much as we tried to do the best we could during design and construction and made particular decisions along the way that have influenced things really positively, there is still more work to do. And one example of that for us has been In the old Bendigo Hospital, they had a 0.5 FTE Aboriginal liaison. The Aboriginal liaison unit was in a rabbit warren upper corridor that no one could ever find. And a design decision was made very early on that the office would be moved to the front entry of the hospital. So it has its own entry adjacent to the main entry. It has its own courtyard. It has a location for a ceremony, smoking pit. I'd recommend to any designers to make sure that smoking pit is not near the intakes for theatres next time you design a hospital. But the space is available and it has its own kitchenette, lounge, space for families to come. And the result of that was, when we opened the hospital, that families felt more welcome in coming to the hospital. They didn't feel like they were coming to an institution. They felt like they had a space that was theirs to come to. So we have a lot more presentations. And now Bendigo Health actually employs 6 full-time Aboriginal liaison staff. So it's a very tangible impact of the expansion of that. But it's still an institution, and like Dana was talking about this morning, or one of the questions was talking about birthing and death in a hospital. Birthing at the hospital is still a big topic. And one of our local Dja Dja Rung elders had done a beautiful piece of artwork that was hung in the birthing suite. And that was noticed by a few Indigenous women that had come to birth, and they felt really special by that. And so we started to have this conversation that if we could take elements from that artwork and place them throughout the birthing suite, that would it feel more welcome. So part of that artwork was about gathering spaces. You've probably all know that symbology of the billabong with people sitting around. And we have wonderful wayfinding at Bendigo Hospital, but now included with that wayfinding, we've taken some of that artwork, expanded into decals. And so at the entrance to our birthing suite is this decal of this artwork. And then in every bedroom is an iteration of that as well. And so to a white woman entering the hospital, it means nothing to me except it's a pretty thing on the wall. But to an Indigenous person presenting, it means everything. And suddenly they feel welcome, that they're in a safe space, that they are understood already before anyone's even said anything to them as they're walking through the door. And so I think it's really important in watching that history, the trajectory of how we're engaging with that community in particular. We have a number of different communities that we engage with at Bendigo. But that community in particular, it's not just a one and done. Okay, we've fixed a certain problem, people are presenting. But now how can we evolve that and encourage even more growth?
Fantastic, thanks, Joan. That's a really, and again, another tangible example of that ongoing stakeholder engagement and how those smaller initiatives can really make a big impact on a lot of people. Kate, I'd like to throw to you now. I guess the ACT government's vision for a person-centred health system is one that is accessible, accountable and sustainable. What does this mean for you, and in what ways can this vision be translated into the built environment?
Thank you. Yes, thank you so much for inviting me to be part of this. It's been an honour to be part of the Canberra Hospital expansion. The government mandate for the project was to deliver increased capacity within the ACT and look at the way that we truly co-design with consumers and how we actually bring them on the journey. So as part of our project, we had a dedicated consumer reference group that we engaged at the beginning of the project in 2018, where the consumers had the opportunity to provide tangible experiences and talk about the emotional connection and what they needed to feel when they walk into a health facility. If we look at the Closing the Gap agenda and the agreement that came through and then the review that happened last year, one of the biggest criticisms of government is that you make decisions for community before you actually engage with them. So the Canberra Hospital expansion previously had spoken to community and said, these are the things that we can affect, these are the things you can change, this is the input that we need from you. We went to consumer groups, we went to our disability reference group, we went to all levels of consumers and asked them what they actually needed from the facility, what connections they needed, what components they would like us to consider, and we closed the loop with them every single time they put something on the table. So when we talk about how we can make community or consumer-centric design, it comes down to asking people what they need and then coming back with the designers, with the architects, and actually delivering on those commitments. It has been an absolute pleasure to see that all the way through from 2018 when we had the project mandate, all the way through to delivery, and walk a group of 30 consumers through the facility that had been on the experience from the very beginning, walking through our Aboriginal and Torres Strait Islander elected body through the facility and having them in tears because we were able to deliver them a facility that actually felt safe. And I think as health professionals and as health planners, we have an absolute obligation to meet that expectation of culturally safe facilities. So I think that's where our government is coming from. Our community is saying we need it, and we are working towards delivering that.
Fantastic. Thank you, Kate. Max, how do we balance affordability with bold innovation in healthcare design? It's a tough one.
That's an interesting point in that I think that is the challenge, particularly working for the public sector on public healthcare facilities. The budget never really facilitates bold innovations as such. So I think that's part of the challenge for everyone in this room to really focus in on what sort of evidence bases we can use to justify those innovations and look at pilots and those types of opportunities to help our government and ministers and executives to make those bold decisions and have almost a business case ready to go. And so to touch on some examples, leading into electrifying hospitals, the Queen Elizabeth Hospital in the west of Adelaide, the new clinical services building that was completed in 2024. Back in 2019, we made the decision to make that a fully electric hospital. And I guess that was at the stage where it was somewhat innovative, still not necessarily much advocacy around that. And I think, it was one of those opportunities where once we looked at the data and were able to, determine that it was going to be more cost effective in the long term, considering increasing gas prices and really leaning into some of those ESD policies, that we're able to make that decision and proceed with that innovation. And now it's almost common practice. It's a policy in South Australia that all new facilities will be fully electric. And that's sort of, aiming to invest in the future in the right areas. So it's always a bit of a challenge in terms of trying to find the balance with innovations. But really using an evidence base and pilots, particularly for government who don't necessarily like to push the boat out and be the first ones to go to the party. I think that's, a pretty major factor in that.
I think leading on from what Max has said there, our approach to sustainability and climate resilience, it's no longer an option. Like it just has to be part of every project that we do, no matter how big or small, as the previous presenters were talking about. Sustainability has to be represented at your organisation's executive level. It can't just sit with the general manager of each hospital. It can't just sit with the engineering team. It needs someone on the executive leadership team directly reporting to the chief executive to be advocating for that sustainability and climate resilience every project, every time. Because all of us that work on projects know that sustainability initiatives are often the first to be value engineered out, followed by the landscaping, followed by, these things just aren't options anymore. They have to be committed to at the very beginning, and they have to be delivered all the way through to the finalisation of the project.
I think building upon those two components, the Canberra Hospital expansion had a mandate at the beginning that we were going to go fully electric. We delivered that. It was never questioned. It was a mandate for the project. Further to that, we went with 5-star Green Star, and we committed very early to that. And so there was never a discussion around value engineering, value management. It was, this is the mandate for the project. It takes a brave government. It takes a brave health service to be able to say that at the beginning. It takes a brave budget to do that, and I think that's something that we need to advocate for, that it is something that we will be mandating. It is something, ACT is very progressive in that regard. Our community has voted our government in for that reason, for that progressiveness, and we will continue to do that. And I think, we need to have that braveness to be able to do that.
Great, thank you. I guess you've touched on this a little bit, but one of the conference themes is climate resilience in action. So, Jake, designers and facility planners are under increasing pressure to reduce carbon footprints, improve resilience measures, and resource efficiency to respond to extreme weather and environmental change. Can you talk a bit more about the work you and your team are doing to respond to climate resilience in action?
Yeah, exactly. I think you're picking up from my previous comments there. It's around commitment. It's around commitment from the organisation to ensure that it's planned for. Sustainability climate resilience can't be an afterthought. It can't be, oh, that tend to come in a little bit lighter than we thought. We've got a few spare mil. Righto, guys, let's find a sustainability consultant. What can we throw in now to make this more sustainable? You have to plan for that stuff at the very beginning for it to be properly effective. I mean, it's standard now, as Max was alluding to, all new facilities are electric. We recapture rainwater. We put solar panels on. John Hunter Hospital in Newcastle did have the largest solar panel array in the world, but I'll just have to check with the Footscray's car park now whether we still hold that title. But, you have to push the boundaries. Hunter New England is geographically the size of the UK. We have facilities, small, 4 beds, 6 beds, 8 beds, right up to John Hunter Hospital where we've got 900 beds. We sought funding and did a LED lighting program. So every facility in Hunter New England is now fully LED lit. There's significant savings in that. That saving comes directly back to each service to provide clinical care to the community. So sustainability doesn't cost more, it saves you money if you plan for it and you implement it from the very beginning. What I would suggest to you, for those of you that are going to go off now and organise these sustainability executive level jobs, keep 20% of those savings to fund your ongoing sustainability initiatives, because the GMs of the facility won't want to give it back to you once they see that saving. So you want to hang on to that from the very beginning and use that momentum to move forward and do more and more and more resilience programs. I mean, any new build obviously is going to have the best glazing, it's going to have the best, but it's how we look after our existing facilities, how we retrofit those smaller sites, what are the small wins that you can do on a day-to-day basis. Push it further, don't just capture rainwater. In our Tamworth Hospital, we now recapture and recycle all of the reverse osmosis water from our dialysis plant. All that water is used to flush the toilets. That's tens of thousands of litres of water that is now, instead of going directly down the drain, goes down the drain, but is used to, it's still going to the same place, but it has a use. We're not using double the amount of water that we were for. You could drink it. It's the cleanest water in the facility. It's been through reverse osmosis, and we just put it straight down the drain. Why aren't we capturing that water? There's projects out there that you can find if you're committed, and you have the backing of your senior leadership to implement those across the portfolio.
And I think that lends itself to, I guess, what Bob and Ursula were saying. It's finding those small opportunities as well. It doesn't always have to be a holistic initiative across the whole hospital. There's specific projects that can be implemented at any time. Max, how are demographic shifts, climate pressures and evolving expectations reshaping healthcare spaces?
So I think I'll probably lean into the changing expectations around climate change. Here in South Australia, our government has some quite aggressive policy positions on climate change. So we've got quite a clean energy grid backed by renewables. There's a target by 2027 to have net 100% renewable energy provided within our grid. We're also targeting 60% reduction of greenhouse gases by 2030. So as part of that, the government has mandated for all agencies to come up with carbon management plans by the end of this year, and to be implementing and tracking some of those measures by mid-next year. And so when we look at the data, and being an engineer, that's where I naturally lean to, we've got some experts in our space who have sort of crunched the numbers on this, and we've found that about 15% of our greenhouse gas emissions come from energy usage. So electrification is significant in that, but there's also, I guess, the use of on-site renewables and those sorts of things. We really need to do a greater push in that aspect, because that's the low-hanging fruit that's able to, make a bit of change in that aspect. From a, I guess, constructability perspective, one of the other pretty major factors from greenhouse gas emissions is embodied energy. So we look at, our concrete and steel structures, and about 5% of our emissions are embodied energy. So if we look at simple, design components like replacement content in concrete, putting fly ash at the Queen Elizabeth Hospital, we managed to achieve about 40% fly ash concrete replacement, which, resulted in, I think, if I'm getting the figures correct, it was over 2,000 tonnes of carbon dioxide emissions that was saved through that particular initiative. So it's these types of aspects and initiatives that you need to think of right at the front end and, to try and be a bit more innovative, look at other options of, replacing concrete or steel wherever possible, where, to use another example with TQEH, we managed to replace some of the structural steel with timber LVLs to support doors. And that resulted in further greenhouse gas reductions and actually achieved efficiencies on site where it was easier to install and no doubt will make it sort of easier to maintain and replace over time. So, when we look at that, one of the biggest elephants in the room is if we look at SA Health as a whole, about 65% of those of our carbon footprint is in operations. So we're talking, clinical functions, pharmaceuticals, consumables, those sorts of things. That's probably the biggest challenge. I think the people in this room are very knowledgeable and are able to tackle the, measurable components, the built environment components that. But it's really the aspects more from a clinical perspective that need a lot of effort. So as part of that, we need to continue to challenge and lean into some of those aggressive policies from our governments on, challenging private, our vendors and our suppliers of equipment and materials and suppliers to really focus on what they can do to improve from a climate change perspective. And I guess the other aspect, and conscious of time, is that part of the changing expectations around climate is increased, frequency of extreme weather events. So just building our facilities with an understanding of what that means, having greater backup generation for our facilities when we have grid outages. Things as simple as bushfire events, the frequency of those might increase. And so looking at the design of our air conditioning systems and focusing on, new and innovative technologies for that, or even something as simple as allowing carbon filters to be put in for when bushfire smokes envelop our cities like occurred, a number of years ago in Victoria and New South Wales. So for mine, that's sort of a bit of a big focus as we design our new facilities and really enable future flexibility for those more frequent extreme weather events.
Thanks, Max. Joan, as the role of the hospital evolves, can it become a stronger hub for community wellbeing?
Yeah, I think we've noticed over time, clearly the hospital has changed the way it engages with the Bendigo community. I mean, Bendigo is 100,000 people and 5,000 of them work at the hospital. So you're either working there, you're married to someone who's working there, your neighbour works there. Everyone has a connection to the hospital. So it started out probably as it's just a building, it's a workplace, and it has evolved over time into the way it engages itself, not just through the foundation that it has or through organised interactions, but in the way people come to the space. So there's a lot more events that are held at the hospital, similarly to, I guess, how Footscray is going to use its village green. But it's trying to bring people to it for not specifically a health-related reason, but being a community hub and organising programs around that that's engaging and creating those connections ahead of time, ahead of people presenting to the hospital, so that there's already those networks established before they're actually coming to present. The Bendigo Hospital covers a range of the provides service for a quarter of the land mass of Victoria. So it goes from Gisborne, which is the outskirts of Melbourne, all the way up to Mildura, which is the top corner of Victoria. So it's a broad range of people that it has to cater for. We've got people who come to Bendigo who have never been in a lift before. And then we've got people who are quite used to an urban environment from Melbourne. So how do you engage people from many different walks of life? A lot of farmers come, and they're overwhelmed when they're coming. So we have an affordable accommodation where people can come and stay. It's just a little bit separate to the hospital facility, but it's co-located on the precinct so that they can come and stay the night before. They can walk through the building already get a sense of the building before they're presenting, but it also means that they're not driving 4 hours in the morning of their appointment to get to the facility because it's the biggest one nearby. And we also have representation throughout the hospital of the different local councils so that you can connect to it visually and say, oh, I know that place, or that place is called Swan Hill, but I'm from Swan Hill, and you're already feeling connected in that way. And what you're talking about future flexibility, we designed it in a way we were lucky with our budget that and the brief that we had planned for 372 beds, which is 9 wards, but we only opened 6 at the start. So we had thought that over the 25-year term, and hopefully it's a 50-year plus building, that we would be able to expand into those wards and have greater access for people. And in the meantime, while those wards haven't been open, we've been able to use them for other purposes, engaging the community in other ways. But that future flexibility is hard to predict, and we've already opened 2.5 of those extra wards 9 years in. But yeah, to talk to your point a little bit more about trying to build in that right up front, you know, the embodied energy of creating a building is already so big. Trying to future-proof it where possible, rather than having to build a secondary building already at 10 years, we've been able to exist in our current building and use that space in many varied ways. And hopefully create that flexibility as the time moves through the project.
Great, thanks, Joan. Kate, you're currently involved in developing some standard components with AHDC and AUSHFGs. Can you tell us a bit more about this body of work and why it's so important?
Thank you. As part of the consumer reference group, we also had delegates that sat on each of our project user groups, and they were given the first 5 minutes of every meeting to discuss what was important to them at that part of the design that we're in, what was important in the rooms that we will be addressing. Falling out of that, we had 10 components that we accepted as standard components that we will be carrying forward in every design that we do in the ACT. Simple things like a consumer PowerPoint. We have all faced that moment where you're watching your child play on the tablet and you're seeing the energy go down bit by bit, and you're having that panic that you know that as soon as that goes out, your child, who is meant to be contained in a bed, is now going to be, up and moving around. Consumers were frightened to pull anything out or to use PowerPoints that sat behind the bed. They didn't want to touch the MSP. They didn't want to touch anything that was going on in fear of, turning things off, or if they were visiting people, they didn't want to turn grandma's life support off. So they didn't want to touch anything on the MSP. So they asked for inclusion of a PowerPoint that was dedicated to them. Simple things like that we then went to AHDC and asked for them to be considered as a standard component within our room designs. The inclusion of sensory rooms, so when you are having an overwhelming moment, that you could go out and be visually and auditory removed from the environment that you're in. Consideration of changing places being embedded in all facilities. So we actively campaigned AHDC and presented these components to them. There was a whole series of delegates that were sitting in the room when we presented, and it was overwhelming how many people thought that they were great components and something that we should consider as standards moving forward. True engagement, true co-design, and understanding what people need in these facilities and how we as healthcare professionals and as designers have that obligation to make that journey just a little bit easier for people. So they are incrementally being implemented into areas within the AUSHFG, and we hope to continue doing that on the Northside Hospital project by embedding consumers and looking at further ways that we can innovate and we can meet the needs of the community. Julian and I will be discussing that more tomorrow. There's other components that we addressed, but it's a really exciting opportunity that we have to get community involved.
I think it's great, kind of that incorporation of things that might be really important to one user group, but actually benefit multiple user groups. Like if you're thinking about the crossovers in a curb, that only got introduced 60 years ago, and it was for disabled access, but actually it benefits mothers with prams, it benefits people in a moon boot, it benefits a whole range of people that weren't originally considered, but it can just become standard design, and by incorporating that in the guidelines then, it reaches a wider range of people that's not necessarily specifically targeted at them, but it's greater benefit of design overall.
Absolutely, and we also recognise that not every design has the capacity to go to a wider consumer group. So this is an opportunity to harness what we're hearing from other people and the experiences and start to embed it.
I'll pose this question to all of you. I guess you've all been involved in various aspects of planning, design and implementation. What stands out as the most important aspect of consumer engagement?
Genuineness. Actually do it. If you're not going to do it, don't do it. Don't write a strategy and tick the box. If you know that you've got a complex group that a standard consultation approach isn't going to work, create something. We get too wedded to things. We get too focused on we have to deliver this plan and that plan and this plan, and we need all these things for the business case. But make it project specific, make it local, make it fit your community, and be genuine in how you wish to apply that across your projects.
Thanks. Anyone else want to comment on that?
I would just say that it's, for us as designers, it is quite time specific. You have a particular project that you're working towards. But if you can think outside of that as well. So, what might you be able to deliver in your project, but what might it build on for future benefits as well? And I think, being clear with that expectation, saying, well, I can deliver this for you right now, but let's look at it in terms of a longer piece of time and what might be delivered over time. Yeah.
I think for me, I think it's about the timing of engagement. You don't want to go to consumers or community and ask them what they want in the facility when you already know what's in the facility. Learning from the Canberra Hospital expansion, we embedded 7 questions into our business case development where you have to go to community and ask those questions, and if you don't, you have to justify in the business case why you felt you were it was more important to not go to community. So we are now sitting with our Aboriginal and Torres Strait Islander people and our consumers before we go to business case and asking them what's important. There is no point in asking community what you want if you can't even consider delivering anything. I think it goes back to what Dana said this morning. There is things that they can affect, things that they can change if you ask them when you're already in design development what they want in the facility. You're beyond that, you're past that point.
All right, thank you. We've got about a minute and a half, so this is a bit of a tricky one to wrap up on, but we'll see how we go. What challenges must government, industry and healthcare providers tackle together to address changing climates and changing communities? And try and keep it brief before we open up to Q&A.
Be brave. I think be brave. Ask those questions, unturn that stone, listen to community and consider how you can actually be progressive.
And I think from a government perspective, it's don't be afraid to partner. You have to use the experts around you, engage the consultants if they're under the scheme and you're allowed to. Those of you who do government procurement share that pain. But engage with local community, engage with local providers, engage with small startup companies, and make sure that you're using them as the local experts for how you can best serve local community from that sustainability, climate and resilience perspective. And be brave and commit to it. And don't make excuses about why you're not including it. That's my take-home message for everyone. If I hear that anyone VE'd out sustainability, it just can't be done.
And I think another thing to add is that budget is always a major issue, and so sometimes it is going to be somewhat of a restrict to what can be achieved. But putting in that future flexibility to enable something in the future, and I know there was a comment made as part of the last presentation that the solar panels were sort of cut from the Queen Elizabeth Hospital project. We did actually install a lot on the car park. I think it was either 270 or 370 kilowatts from memory. But part of that sort of decision making was we have still implemented the infrastructure. So we've got a roof that can take solar panels. We've got the infrastructure in terms of the cabling and switchboards ready for, I guess, those panels to be installed at any time. But, part of that decision-making process was, well, where we've got a very tight budget, what are we going to prioritise in terms of those energy efficiency opportunities? And electrification was certainly the strong priority from that sense. So enabling future flexibility through whether it's expansion, spare space, or effectively redundant infrastructure that's there ready to enable those future provisions. That's certainly a major component.
Great. All right. Thank you, Max, Kate, Joan and Jake. That was a fantastic discussion, but you're not off the hook yet. I'd like to open it up to the audience. If you've got any questions, please pop your hand up.
Simon Williams here, Oricon. A lot of the conversation around user groups, not user groups, community consultation. What lessons learned from those conversations can we bring to user group consultation? Because I think there is sometimes some overlap between the two processes. So just wonder your thoughts on that.
We embedded community and consumer in our user groups. So from the very beginning, they sat side by side as equal partners. We did have dedicated focus sessions, but we brought our clinicians and our advisors along to that. So they were stepping into the community realm, or the community and consumers were stepping into the clinical realm and sitting with everyone. So that true collaboration. There was crossover, but we always went back and closed the loop with people and made sure that they understood the reasons why, if they were asking for things, we couldn't do it, or how we were using the information that they gave us and translating it across to other areas that we hadn't previously considered. So truly sitting people side by side.
I think too, Kate, it's being, back on the back of what Kate has said there, it's being understanding what your consultation is for, what you're hoping to get out of that consultation. Consultation for consultation's sake is not only a waste of time, it's unhelpful, it's potentially dangerous. Be very clear as a project team what the intent of the consultation is for. Be very specific about the people that you invite to that consultation. Make it clean, make it tidy, and just be very specific about what the outcomes are from that consultation.
For me, just something on what Kate said about the word translation. One of the things that we have taken away from our user groups is making sure that what a designer is saying and what a layperson or a user group is understanding are actually the same thing. So we might have a great idea as a designer and think this is actually, this is going to work, and what they're telling us is something different, and unless we're actually talking about the same thing with the same language, that can often be misinterpreted. That was our biggest takeaway.
Any other questions?
Yeah, just a quick one here. Oh, that's loud. Just a quick one. So we all talked about how the budget suffers and sustainability is one of the first things that gets cut. Is there any matrix, or is there any register, or is there anything where you can quantify certain initiatives in sustainability to have that to support a business case, so then you're less likely to suffer those cuts? And that might be for anyone in this room.
I think I'm aware that there is discussion and policies around carbon prices, which, if the government is bold enough, they might make some decisions on implementing, a carbon price on aspects, of our, healthcare facilities. And if that's to occur and sort of taking the trajectory that the SA government is taking, I'm expecting that there's going to be a much greater focus around that, which will, instigate those changes and almost make it a mandatory or a requirement to consider that within our business cases and advocate for the additional funding to enable those changes. But without that change, and without some of those policies, it's not necessarily going to happen. So, it really does need that, a number of the other panel members have talked about it, the courage from certain people and powers that be to make those calls. And enable that to play out. Even thinking back 5-6 years ago, before sort of electrification was really taking off, it took a few, I guess, bold calls to enable that for someone to be the first to sort of implement that, pilot that, and demonstrate that it's feasible, and all of a sudden it somewhat changes the game. But the ones that are more difficult, like your embodied energy and those sorts of things that don't necessarily have a tangible ongoing cost benefit, they're the ones that really need some government decisions or otherwise financial incentives, and whether that's funds or carbon prices to sort of enable that.
For us at Bendigo, it's a regional hospital, so we're only actually on one power grid. We don't have any redundancy like the metros do on 2 power grids. So a lot of our backup power is gas generated. And so we have been tracking the costs increasing over time. And so it's clear and quantifiable how much it's costing the health service to keep running on gas. And there comes a point where it's going to be equal or more expensive to keep operating on gas than it will be to figure out a way to fully electrify. And so just tracking that over time and being able to present that to them has allowed us to operate our machinery differently to save some efficiencies, but that's going to reach a limit at some point where we have to take that next step, and having that data is really useful.
I think that's key. It's the lessons learnt. It's what the savings that you're realising in work that you've already done, and it's making sure that your organisation has the maturity to capture that in a way that you can then use that data meaningfully. Like, as I talked about, sustainability has to sit as a team within your organisation to do that work, which in Howell, New England, we have a fantastic sustainability team who said, make sure you tell them that we've realised $3 million in savings, and that money's gone back to direct clinical care. So unless someone's tracking that and can demonstrate that, it's hard to then justify spending the money up front to implement those initiatives.
Thank you. We've probably got time for one final question.
It was just tapping in on that evaluation. Have any of you done post-occupancy evaluations on your projects, or are we seeing that kind of thing? Is it difficult to be implementing them? What's your experience after the fact?
We just undertook a post-occupancy review as part of our closeout of our business case. So we tracked very, very well on our post-occupancy review. There was a few little changes that we are now going to implement as part of our new project, but overall the building performance was phenomenal. Our 5-star Green Star is done after you've gone operational on the building, so we got really highly commended in that, and we were very close to going even 6-star with some of our components that sat there. So in terms of the consumer components, we did phenomenal, and there was amazing feedback from the clinicians, and then from operational sustainability, etc. Tracked really well in that. I'm not sure if that document will ever get fully released, but we do have an intention of doing a formal post-occupancy 2 years after.
Any of the large projects that are run through, Health Infrastructure New South Wales or Health Infrastructure Queensland, there will be a formal post-occupancy evaluation that's done on all of those projects, as fairly standard, as my understanding.
Fantastic. Please join me in thanking the panel, Max, Kate, Joan and Jade. I think you've given us a lot to think about leading into lunch, which I'm sure you're also keen on. So please head outside. Lunch will be there waiting for us. And we will see you back at 1:30 for the afternoon session. And if I can just grab the AHDC past and present committee members just by the media wall, we'd like to have a photo opportunity as well. Thanks, everyone.